As far as multidisciplinary, I'm going to hand over to Wendy.
So a multidisciplinary role in rheumatology, we know, Corinne's done a great job of going through, where we fall with rheumatology, what we have to pay attention to, our patients with rheumatoid arthritis, medicines that we have them on, the systemic sclerosis, and how are we going to communicate with them. So I did start multidisciplinary discussions in my clinic, as well as combining with our pulmonology groups in Wilmington. And we have a thoracic radiologist that we work with as well. We have, 2 hours away, the closest Dr. Morrison at Duke, who's a pulmonologist, and sets us up with his patients that it takes too long for them to get to a clinic. We're recognizing the patients at risk for the comorbidities with the interstitial lung disease, the screening, the systemic autoimmune rheumatology disease, and recommending any additional assays that they need to do. Recommended therapies, assisting with acute flare management, and maintenance of therapy selection. Selective autoimmune rheumatology diseases are associated with about 25% of ILD cases that have been identified. We can see the diffuse cutaneous systemic sclerosis, idiopathic inflammatory myopathy, Sjögren syndrome, rheumatoid arthritis, and lupus. And really what the importance of this session today is really for us to see, and there's a lot on this slide, is what is our rheum-pulmonary connection with regards mortality. As Corinne had said, time is long, and we can see with our disease states, whether it's rheumatoid arthritis, lupus, polymyositis, dermatomyositis, systemic sclerosis, Sjögren syndrome, where ILD will fit in there as well. So monitoring our patients for acute exacerbations, following them, and we see what ILD and pulmonology clinics run into with their patients with either septicemia, hypertension, other comorbidities. So the goal, again, of the slide is really to make it a point that our rheumatology patients can die of ILD-related causes much more frequently than the general population. So it's just important that we are able to monitor any of those patients for acute exacerbations. I'm going to let Corinne finish up. Thanks.
No problem. Okay, so ACR came out with a great screening guideline for patients looking at their PFTs and high-resolution CTs. For those of you that, just in case you don't know much about CTs, high-resolution, what makes it different is that 20 years ago when I started, we actually had film with CT cuts that we'd look at on like a light board. But we, back then, they would take 5 millimeter slices of lung tissue, whereas high-resolution imaging now goes down to 1.25, and some of them are 0.65 millimeter slices of lung tissue, so it's very fine. We can see very early disease earlier in those high-resolution CT images. They also prone your patients during that study because there can be a lot of dependent atelectasis, especially in obese patients. So we'll see this peripheral, is it atelectasis? Is it interstitial lung disease? We're not quite sure. And then we prone them, and when the lungs kind of fall forward, it kind of straightens out and looks clear, or it doesn't. And we know this really is an interstitial process happening. So just so you know, that's a difference between high resolution and regular imaging in those patients. They don't need contrast with it unless we're looking at pulmonary arteries or lymph nodes or something else along those lines. So also you want to make sure your patients can prone. We have some patients that can't do that. We'll settle for a non-prone but still high resolution with fine imaging. All right. These patients may get a bronchoscopy, but again, only if we're suspecting underlying infection, especially if you all have put them on a lot of immune suppressive therapies and now we think they've got a fungal infection or something weird. 6-minute walk, we watch over time to see if these patients are able to maintain their walk distance or if it's starting to decline. Musculoskeletal joint issues are going to get in the way of our 6-minute walk being a valid test for us to use. If their body is giving out before their lungs do, that's not a very useful test for us, but if they are able to ambulate, that's something we try to measure. Again, biopsy is recommended against, but may be pursued if our imaging is, again, we just need more information before we can really definitively say what's going on with that patient. But we do try to avoid it nowadays because now we have therapies that are approved for progressive fibrotic phenotypes, right? It doesn't matter what's causing that fibrosis. We have therapies approved, so we no longer need a biopsy to find out what it is. All right, so this disease, we usually trend their pulmonary function testing, usually every 3 months. If they've been stable for a year or two, they are not showing a progressive phenotype, we likely are going to reduce the frequency of their lung function testing. But oftentimes we are doing lung function every 3 months. So if you are trying to hold out and manage and pretend to be a pulmonologist while you're waiting for them to get in, right, into a pulmonary practice, you can at least start ordering the serial imaging until they can get in and serial lung function test those patients. We want to make sure that we're looking for desaturations in their oxygen levels, and oftentimes you're going to find it first with ambulation. Oftentimes at rest, unless they're obese, we're not usually going to see that, but with ambulation, we're likely to see it first. And then with high-res CT, you want to reorder that if we are seeing decline in their lung function or they're having worsening symptoms. And those symptoms aren't always dyspnea. Sometimes it's cough, a dry, hacking cough. Sometimes they may try to excuse it as allergies or postnasal drip or something else, and it might be, but oftentimes it is because they're having progression of disease. With patients who have a history of RA-ILD, or any of these other connective tissue disorders, the pulmonary function test again stays the same every 3 months or so, depending on how they're doing, how they're progressing or stabilizing, and then checking their ambulatory desaturation tests and high-res CT just like before. So these patients have a diagnosis of clinical ILD. If there's overt symptoms, we can see it on their high-res imaging, or their lung function is declining, is less than 80. 80 is considered normal. Or they have subclinical evidence of ILD because they have, no overt symptoms, but they do have some radiographic imaging that's making us concerned for ILD, and their lung function is still preserved. But we're like, you feel like you're an interstitial lung disease patient based on your lung imaging going on, because sometimes they are not symptomatic until disease is progressed. Are you guys familiar with this ACR? I see a lot of heads shaking. Okay, I won't spend a whole lot of time here, but it's talking about first-line therapy based on systemic sclerosis, myositis, multi-connective tissue disease, rheumatoid, and Sjögren's, and what first-line therapies are recommended and when glucocorticosteroids are recommended in these patients. For cyclophosphamide, when we're giving that to patients, I know a lot of times in pulmonary, when we're using this, like with vasculitis, we prefer to do infusions. I'm sure in rheumatology, the same. Oral therapies, we did see higher bladder cancers and some other issues. So I want to be very careful with that as far as safety, efficacy, monitoring labs over time with these patients. And then with mycophenolate, there was this subgroup analysis of patients with mycophenolate did show improvement in their predicted forced vital capacity, who also had overlapping interstitial lung disease. Rituximab, this is a phase 2 randomized controlled trial looking at rituximab with cyclophosphamide together. And they looked at patients with different types of autoimmune-related lung diseases with the interstitial process. They found no difference in the change of their forced vital capacity from baseline. Both patients actually had an improvement in their FVC at 24 weeks. So they were efficacious there. Non-superior to each other. As far as rituximab, there's another EVER-ILD study looking at, again, patients with SARD-ILD, idiopathic interstitial pneumonias. Those are the COP-BOOP, ones that we talked about, organizing pneumonia, NSIP, and they looked at these patients with high-risk, that were diagnosed by high-risk CT, and then they looked at them with combination therapies, followed them for 6 months, and they were looking at the change in their FVC over time based on the combination therapies that they were on. Azanthropine, there's very low evidence for azanthropine right now to be beneficial in these patients. There are some small open label prospective trials going on. They're not randomized. And right now, guideline is just saying based on your clinical experience and considering it as an alternative therapy for your patients with SSc-ILD. But there's, again, not very hard evidence with that right now. As far as escalating therapy in your patients, if there is evidence of your patient is having progressive phenotype based on their symptoms, their CT imaging, or their lung function, that's when we want to start talking about being more aggressive. We already talked about the progressive phenotype with the decrease in their FVC, forgive the one there, by greater than 5%. With increasing fibrosis on high-res CT or declining of the, I think that's supposed to be the DLCO, yeah, of 10%. So forgive the typos there. All right. I think we covered this. How are we doing on time? Does anybody have time? Okay, so we'll rush through these real quick so we can get to our breakouts and stand up and not hear me talk anymore. Here's an tentative trial looking at patients with diffuse cutaneous disease, patients that were receiving background mycophenolate at baseline on a tentative therapy that we talked about.